All right, so students are area track CBA they talk to you about some type of crisis that we're experiencing, not just in the state of Michigan, but in the country. A lot of patients with autism spectrum disorder, and what we do really being boarded in our emergency departments, hospitals, all across the country. This is not just something that happens in our state. So I want to talk a little bit about the situation, what efforts we're putting forward. You're a professional. I would like to tell you a couple of things that we can do to make it better. I also want to be realistic. You're here expecting that I have some natural solution for this problem. That's not the case. I wish you did, but I don't. But I will give you an explanation of what's happening, why it's happening, and how can we make it better, and the efforts that we're putting in place to make it better. Okay? So I want this to be interactive. If you have any questions, feel free to raise your hand. So yeah, this is all over the news. Not just Michigan, happening in Boston, New York, Philadelphia. If you go Google and type autism emergency department, you're going to see so many of these articles. A lot of patients with autism that are living in hospitals. So some of them are there for weeks, some of them are there for days. We have patients who've been there for months, waiting for appropriate care, waiting for appropriate treatment, waiting for bed. We have parents who come in and say, "Do this anymore?" So we started getting a lot of calls from our emergency department on what we do, how to treat, which is coming home. Everywhere. It's happening everywhere. Go online, go on YouTube, search it, you're going to see it's everywhere. There are parents in Philadelphia. I also read about parents who are giving up their parents' rights, right? So the state then has to intervene and find a place for solution, which is, I'm a mom of 3 young children, giving up my kids' rights so they can access care, which feels like the craziest thing in the world. This is something that my team is very passionate about, helping these families, because we see it over and over. It's the same movie playing over again. So I just wanted to show you. And we noticed this is an issue that we've been keeping track of for a long time. During and post-COVID, which is became 10 times worse. Before COVID, we had the spaces right there for you to go to help our emergency departments. We were even both like we were still in the middle or towards the end, right? But it's 10 times worse, and it's only gotten worse. I think COVID exacerbated the gaps in care that we already had. And a lot of our girls lost services, lost school, lost structure, lost the sense of routine, which only made things worse. So, my goal for today, like I said, I don't have a solution to this problem. I wish I had it. I don't. But at least I know a little bit about it and will be able to make it a little bit better. So my goals. Okay. I want you to learn about this crisis that we have in our state. I want you to know why is this happening. What are the reasons? I would love to help you identify potential solutions and what can we do as professionals, as parents, as providers, to make this better. And identify how to prevent this crisis. So let's look at some numbers. My favorite quote is to treasure what we have, right? For us to be able to make good decisions, we have this data. So we're making rational, good decisions based on numbers that will hopefully help us identify solutions. So, psychiatric vets in Michigan. There's a report on Google that if you want to look it up, it's a work group that was done in 2018 in Michigan that goes over this problem. We did a lot of research, we did a lot of different players to get at the table and said, how can we make this better? So they did some research on amount of vets, psychiatric vets in Michigan. So let's look at adult vets. In 1993, we had 3,041 adult psychiatric vets in the state. In 2017, a couple years ago, we had 2,197 vets, or dogs, right? And I'm sure a lot of you are familiar with the situation that in Michigan, when you turn 18, you're supposed to outgrow your autism. You wake up, and it's supposed to be gone, right? Because insurance won't cover, at least private insurance, about Medicaid, insurance won't cover any more services. So when a lot of these families not all. This is for the, let's look at vets for teens and children. In 1983, there were 729 vets. Look at 2005. 276 psychiatric vets for teens and children. So that is a 63% reduction. When we should be going in the opposite direction, we should be seeing an increase, right? So now I want to show you an interesting data point. Oh, sorry, that's no. So Center for Disease Control estimates the latest number was 1 in 44 children is diagnosed with autism spectrum disorder, right? So I think it's very important to consider that it's 1 in 44, but as we all know, the spectrum appears light. So this includes estimating a little bit of local social skills, but are going to be able to live independent, functional, life. They're going to be able to live independently, have a job, pay their bills, and just to make it a little bit out. Then we have the opposite end of the spectrum, which is someone who needs care 24/7, right? So I think, sorry, not sure what that happens, so I'm not going to go so I guess what I'm saying is, this is an interesting number, but we need to realize that each kid is different, each individual needs are different. So, boys are 4 times as likely to be identified as girls, right? There's way more boys than girls. Okay. And then from that sample that we took, 35% also had intellectual disability. So not every person from that 35%, but a large group of those individuals are the ones who really need 24/7 care, right? And I know a lot of you have seen, the autism movement out there about autism being an identity, which I wholeheartedly agree with, right? I'm all about being proud of the identity of neurological, but we need to realize that that's not autism for everyone. Autism manifests differently in every individual. So our goal or our job is to make sure that everyone gets the support. Everyone receives the support that they need. So now let's look at another interesting number. So you remember how the adult vets and the children vets are going down? Now look at the prevalence of autism. The number is diagnosed with autism over time. So in 2000, 7 kids out of 1,000 kids, 7 kids were diagnosed with autism. Now look at 2018. 1,000 kids, 23 have autism. Right? That interesting how the trend is going the opposite direction of the psychiatric vets. And the interesting part too, the psychiatric vets, in a psychiatric hospital, people get medication management, right? Someone who has, bipolar or, suicidal or mental health condition, they receive the care of the healthy. But someone with autism, There's the medication, that's in the truth, you know. But the therapies that we have for bipolar or people with mental health conditions are not, for the most part, right, are not going to be effective for people with autism and developmental disabilities because they need different service. So even if we have the right amount of subjective tests, which I think would make it a little better, it's still not sufficient. Because these people need is access to evidence-based treatment. They need a behavior analysis done by people who know how to do it, who have experience with behavior management. So I think having more psychiatric tests can help, right? So I would say where I see success with this population with severe problem behavior is a lot of time medication management is not going to do it. You know, skills don't teach skills, right? You're not going to teach someone to tolerate noise, how to tolerate, accept no for an answer, all the skills that patients usually need to be taught, right? So medication alone does not teach them skills. So in my experience, what I've seen is when they are under a good medication regimen, what happens is the intensity of the behavior decreases, so you can teach them. Right? Because for you to be able to teach medication to someone, you need to be safe, right? They need to be able to sit down. They need to be able to be calm enough so you can have a teachable moment. But when you have someone out of control, it's very different. So, in my experience working with this population, the program I report, I used to work at a residential facility in Philadelphia. Where I saw the kids really thrive was when they were under the right medication management and the right treatment support. Only they sometimes didn't do the trick. Only medication did not do the trick. The combination of both worked very nicely did the trick. And then when we would go, so like the medication management was done with good data. So company. So that's something that I've seen too, where there's a lot of medication changes made through this population without real data. It's mostly done based on caregiver depression. And I'm a caregiver. If my kid was really rough the day before, I don't even tell you he's been terrible. But maybe he had really good 2 days prior to that. But then the medication is made based on that little, recollection of events. So that's why it's so important to collect the data and make those medication changes based on data. But this is just to show you how these trends are going the opposite direction. So before looking for care in our emergency department. So this is a study, and I put the study here so you can review it if you're interested. Children with autism are 9 times more likely to make a trip to the emergency department. Why do you think this happens? Anyone wants to guess? Behavior issue, that's a great one. Yeah. And a lot of times, people with autism have communication challenges, right? So they don't know if they something hurts. So when the caregiver realizes there's something wrong or that they need medical care, they're ready for the emergency department, right? They were not able to verbalize, my stomach hurts or my leg hurts. So that also contributes to this increase in visits. The other thing too is there are a lot of people with autism have a lot of mental issues that make them more prone to have more DR visits. This is another interesting point that was found is that children with private insurance were 8% more likely to than people who had hospitals. So if you want to get more information, there's some information. So let's talk about a case. This is a 14-year-old male with history. So this is taken out of the patient's chart. I got permission from his parents to share this information today. But I just want to show you exactly what this patient or what this situation looks like when they come into the emergency department. This is a 14-year-old male with history of autism presenting for aggressive behavior. Family reports The patient had been worsening and aggressive and violent behavior over the last several months. Patient has things such as grid balls, solid shirt, grid glasses, and punches. The patient's father is interested in long-term placement care as it isn't safe for him to continue to care for him in the current home environment. He did take the patient to hospital X over the weekend, however, was told that he would need to arrange this himself on an outpatient basis. He states he has called several facilities without any success. Given the patient's continued and worsening aggressive and violent behavior, he brought him here for further evaluation. So this is copy-paste chart. The rest is copy-paste on chart. So this is a perfect example of the parents who try to get the supports, who calls facilities, who tried to get supports for his child, but was not able to be successful. And when things got really difficult to manage with him, he went to the emergency department. And the truth is, like, he was hoping to get help, right? Like, nobody takes a kid to the just because we have nothing else to do, right? Or for something. He was hoping to get the help he needed for his kid. I'll tell you what happened with this kid. He stayed there for a couple of days. They gave him medication. In one of the psych hospitals, I can't remember which one at this point. But he regressed. He went back home. He lost skills. He was able to shower before going in. Now he was not able to do it. It was a very traumatic event for him, for his dad, for the entire family, because it was not a pleasant experience. He was not around peers that were his age. He was not around peers that had the same issues he had. He was around people, again, who had different psychiatric issues, but not autism. So, if anything, it made things worse. To the point where dad told me, when he goes off, I threatened to take him there. And he said this with tears in his eyes. He's like, this is the only thing I can do to keep him safe. And that worked for a little bit, but obviously, like, you realize they don't need what he's saying. So that's not. But I guess what I'm saying is, like, I don't think psychiatric that's what we need. We need a residential facility. Good ADA support. And we'll follow in setting. And you know, this I see it over and over and over and over again. You know, a lot of patients start the same story. And I think what happens is when a kid is 4, 5, 6 years old, they go into the tantrum or into the behavior crisis. First of all, we don't think much of it because they're adults, which do this thing, right? So then you pick them up, put them in the car, saying, go, you know, they're physically the animals. When they, you know, we start seeing this patient when they're 8, 10, 12, 14, when they grow inside, that's where it's very difficult to manage. Okay, so what happens today? And after trying to get resources, support, and treatment for the kids, can't find that, right? Sometimes they're like, we had parents that I need a sleep and do this. They go into the emergency room for care. So what happens is then you have the emergency department team calling every hospital in the state, every facility, trying to get this patient to submitted. They have to call multiple times, trying to find placements. We were in a situation where placement was found, and the patient came back within a week. Because if they're the home, it was a group home, they were not equipped to manage this very visitors. So the patient was back in the week. So imagine being an emergency department nurse, doctor, medical assistant, and having someone who was in a car accident, who they had their leg chopped with 3 pieces, who need, you know, emergency surgery, and then you have a 16-year-old jumping on the bed, screaming, in crisis mode. Hard, right? So the amount of pressure that this is putting on an emergency department is huge. And what really, I don't want to say breaks the heart, but kind of breaks the heart, is parents do this out of trying to get care for their kids. But it's a no-win situation for everyone involved. It's a no-win situation for the kid. It's a no-win situation for the parents. It's a no-win situation for the hospital staff. It's a no-win situation for the other patient. Imagine being in the emergency department because you were in a car accident with your leg chopped in three and having someone running around you in crisis and the people who are caring for you trying to calm them down. No, it's not. It's no-win situation in So this is putting a lot of pressure on hospitals, a lot. And I can tell you, I've talked to nurses, doctors, and leaders, everyone's just like, what do we do? And the other thing that to me is very interesting is if you go through a checklist of what some of the functions does not need to calm down, it's everything that you would describe in the article, right? Unpredictable, loud, sensory overload, people coming and going, just very high pace, structure. You get new people all the time, there's shifts, people come and go. It's the opposite of what some of the Autism will need to come down, right? So I'm not judging or I'm not blaming parents for taking this care. I think they go there with the thought that something good is going to come out of it. But 9 times out of 10, it's the opposite. So one thing is to go into the emergency room for a medical reason, right? I'm not saying parents should not take a trip to the emergency room. Your job is a medical emergency, yes, take it to the emergency room, right? But if it's for a behavior crisis, it only makes it worse. It really does. It only makes it worse. But then a lot of times also what happens is they go through the crisis, the parent calls 911, the police show, and they're like, okay, maybe thinking that that's the right thing to do. But in reality, it only makes it worse. Because the patient, and then the other thing too is, when you think about how hospitals work, if someone is in the emergency department and they're doing better, they move them into a lower level of care. One transition right there. So when the patient's getting used to being there, they get some predictability and they start to feel a little bit comfortable, let's move them. They're doing better. They don't need this care anymore, right? Let's move them into another unit. Boom, start there. So it's kind of like, but a lot of parents unintentionally making this the right thing to do. Like I said, 9 times out of 10, it actually makes it worse. And then the other thing too, emergency departments don't have the skill set to treat this population. The behavior part, right? I'm not talking about medical injury or. So they go to school to treat like their injury. I think it's my speaker on my phone. Anyway, I learned my lesson. So yeah, they go to school on how to treat life-threatening injuries. They don't know how to care for our kids or our patients. So it's really hard, and sometimes unintentionally they do the opposite, right? They do verbal de-escalation. We all know that for patients with autism, verbal de-escalation is the opposite of what you should be doing, right? So yeah, it puts a lot of stress. Our healthcare workers are very tired from COVID. There's a lot of burnout. It's really hard to get finished right now. And then on top of that, now with COVID, they also have this crisis going on. So it's been really, really challenging. Let me make sure I check this time. Okay, we're good. So boarding consumes the emergency department resources. We have people caring for resources that we should be utilizing to treat car accidents, really medical emergency. And then the other part too is they're not getting the care that we need. It's not like they go to the ER and they're receiving good support. It's a lot of times it's medication management, sedation, because that's another way to keep them safe, right? But it's not like they go to the ED or the hospital and they get the treatment that they need. They don't. If anything, you do laser appropriate care. So you have someone in the ED or in the hospital for 3 weeks not getting any better, taking resources that could be utilized for to save people's lives, right? It's just, I mean, it's a horrible situation. And then it reduces beds available to treat life-threatening injuries and health conditions for other people. So enough about the problem. Any questions so far? I basically wanted to describe the issue. Yes.
Hold
on, I'm going to put the microphone.
So that's kind of like not discrimination against them, like not
Honestly, that may be the report that I mentioned, the bottom, what I found was a data point, that basically is the admission that they had, that information is not. But yeah, there's. Any other questions about the issue? No, she's saying there may be some, legal law move within the bottom that showed you that it takes with private insurance where it's 8%. Like we should have
Are there, I guess, how many residential centers you're mentioning that? That would be good to have more. How many residential centers?
So the residential centers that provide ADA, I know a couple, 2, 3, not part of that. And I think each one has like 12 beds. So, I mean, I could be wrong and make any other information, but from my own research, it's 4. Residential that provide ADA, right?
Yeah.
Sure. I've seen this work when I was in Philadelphia, the work convention, and I worked with residential. And kids will, they're severe twice a year. So they will go there and spend there sometimes a year, sometimes 6 months. And then they will work on their behavior, and the goal is to train the caregivers on the behavior plan, and then the kid will go out. Sometimes it will impossible, you have those kids who don't have a home to go back to, right? But the goal is to reunite it with me. And there's also other programs that are kind of like intensive, so there's for 3 months. This kids are there for 3 months, we work on behavior. But I also think it's very important, and this is something that I tell the parents don't make a deal all the time. We need to factor those expectations in terms of like, even if they get admitted to long-term placement, the goal is always to come back home. And I think what happens is our parents, the parents that go to these, are so tired and burned out and frantic. But what happens is a lot of times we're like, okay, let's do your training so we can teach them how to make it. They're like, I'm done. And I'm like, it's our fault. We're late to the party. You're gone. But yeah, so even if you're, and what I try to explain to them is, even if you're tired, gets accepted into the long-term care program, well, it's good for them to go back home. So you're going to need to figure out how to manage these behaviors, and we can help you do that. But this magic place where you can, if they can live there forever, it's not, it doesn't exist. So, like I said, I don't have a solution to this, but what I know is I know a lot about the problem, but I wish I did. But I feel like I know enough about the problem to be able to make it a little bit better. I know this is very easy to say, but difficult to do. More BCBAs trained on how to manage severe problem behavior. Severe problem behavior is kind of like a specialty in the case. So for someone, I personally have some experience in severe problem behavior. I would consider myself an expert. This is something that is a problem in our state because insurance, the law passed in 2013 to allow us to build insurance for services. So most BCBAs in our state have been practicing for less than 5 years. That's an issue. That's a big issue. Because for people to be able to treat severe problem behavior, they need specialized training, specialized mentorship, specialized, So I think it's easy enough to like 75 8 in our BCBAs have been practicing for less than 5 years. So that's a problem. Right? We need more community resources that will address the needs of children, teens, and adults. And I say community resources, I know it's a big term. But like I was saying before, someone who has mild autism and social skills training needs a level of support completely different from someone who needs 24 hours, 7 days of care. Our community and our system need to have all these layers. So not all is essential in our system, but we need to have qualified professionals who are making this. It's kind of like a triage system, right? If you go into the ER, you go into a triage nurse, and they send you depending on the severity of your, that's where they send you. We need something like that, but we need a system that will be able to catch these kids and put them in the level of support they need, right? That's what we need, not criticism, right? And then we need to disseminate ADA and everything. Why? I know I'm a CA and I'm biased, but what I tell parents all the time is it's very important to learn to discriminate and to differentiate the difference between something that is recreational nature, right, versus something that has evidence-based treatment, where there's lots of research to show that it actually produces change, right? So art therapy, music therapy, sports therapy, food therapy, all these therapies are recreational. Kids love it. The same way my kid loves soccer. The same way kids like piano lessons, right? Kids love them. That's why you don't see leaders when they go to these activities. And that's why the parents are like, he's doing great, he loves it, it's been life-changing. Well, it's recreational, he's enjoying it. So that's no different than signing your child for soccer. And I guess what I'm trying, I know what I'm saying is very controversial, but I own my words. What we need to learn is that our resources and our time are limited. So if you want to treat your child or your loved one's autism, the majority of our resources need to go to therapies that have lots of research behind them, that are evidence-based. Therapies where the medical community supports and stands behind, right? Because if you say, okay, I'm going to sign them up for art, music, sports therapy, then you're consuming your energy, right? I'm a working mom, I have 3 kids, my energy and my resources, my time is very limited, right? So if you're putting your child in all the therapies that are recreational, and again, no parent wants to do something for a kid, but you may not live enough time or resources to really sign them off for the therapies that are going to help treat your autism, right? So when a kid is in art therapy or sports therapy, they're not working on behavior modification. They're not. I mean, they may be working on, they can work on communication, right? They're asking for their advice. But if they don't have like a behavior plan, fill out position plan, written by a BCBA who knows how to teach all these skills for that, that's recreational. We like it. We enjoy it. It's therapeutic when they calm down. It's not treating the autism, the core symptoms of autism, right? So this is very important. Parents need to learn to put the majority of the resources to the therapies that are supported by the medical community. And then if there's extra time and resources, let's do the other therapies. I have nothing against the other therapies. I think they're great. But I like parents to learn the differentiation so they can allocate the resources much to kids, right? And then this is something that we're working very hard. Train the parents how to face and manage the crisis. Because if a child goes into crisis, and you can safely manage the crisis at home, then you don't need to do a DR trip. And then you don't have, you avoid all the drama that comes after going to the ER. Okay? And then something that we're working very hard on is training emergency departments to care for this population. We want to make sure that our doctors are trained, our nurses are trained, our medical assistants are trained, that they know how to provide care for someone with autism, whether it's in the emergency department or if you go into the dermatology department, right? Any questions so far? Right.
Everyone feels very
Yeah, that's great. We have, firsthand experience. So yes, we are doing a lot of training for emergency departments. We are training the nurses on how, what is autism? What does autism look like? How do you tell someone may have autism, right? Because a lot of the patients that are going now, we're not diagnosed. So we also have that, right? Someone may not have autism on the chart, but they still have it. So we're providing some behavior management training on how to best care. So example, what I was talking about, like transitioning them from to a lower level of care. So we're providing training specifically on how to manage this population when they come into the hospital. So we're doing groups of training with the nurses and the doctors. And there's also, we're doing some research, we have a commercial out there, very cool one, for doctors. So we're trying to, even like right now, we have residents come to our program, to train doctors from, med school on how to work with this population.
To extend that to first responders as well, because we as paramedics, we see a lot of this in the field. We are usually the ones that take the children to these hospitals. And that's, I mean, the session here is the whole reason. So we learn how can we help out there in the pre-hospital setting. Parents are the ones telling us what's going on. Like, is there some sort of training or something that we can do to
First, I need information, so we can talk about operations. But I talked to, people that attend the crisis that they need, but not people take it. So I want to talk to you separately. I know the Alliance is doing trainings for first responders. Yeah. So I think they do, I've actually posted some of their trainings to our program. But I will talk to them and see if I know they offer information.
Having comment, so accommodation workers. So, several cases where like behavior are so severe, you can't get anybody to make it. Those residential places we talk about, so state of Michigan, people did not really know that it's severe for us. Parents that are stuck with what we do, like there's this level of here. It's just so frustrating.
It's frustrating. And not that the state that it's different and better, but it happens everywhere in the state. I think your mission is worse than in other states, but it happens everywhere. It's happening. I mean, when I first moved to Philadelphia, Michigan, there were 360 cases 7 years ago. Now there's like 1,200 has been on the state for the last 7 years. Maybe more right now, but don't go get the numbers. But I guess what I'm saying is I completely agree. It happens here. But Friday is exactly what I recommend. We go to the AD thinking, okay, this is my only option. In most cases, I think it's better to have a crisis plan home. If this patient goes into crisis, these are the steps we're going to take until it comes down and stay home. Because once they're in AD, it's like you said, it's either vacation or like they are limited, right? So yeah, I think this is why this is exactly, I'm glad you brought your point, because this is exactly where I feel like BCBAs we can make a difference, is we train parents how to navigate a crisis at home. Because in a crisis situation, you don't think I don't know how to do that, but I'm thinking the opposite of what you should be doing, right? So if we train our parents on, if their kid goes into crisis, if there's some steps you can take to make it better, and then you can avoid that with the trip. That it doesn't solve the gap here, but for some kids, it's going to make it better. And I've talked to so many parents who are like, if I would have known what a headache it was your baby, I would have done it. And that's, a lot of times I'm training them to prevent a readmission. This parent need what we, and I talked about specialized case managers, right? Because a lot of times, the case managers refer to like mental health or most of this kids don't. They need good services.
So they need to have ADA providers.
Well, yes, but I think it's not just little bit, I think it's also expertise. Because as an ADA provider, if you take us to your kid and you're not qualified to take them, then you're also breaking your code of ethics. So providers are in a sticky situation. Because you're being told, like, you can't take it if you don't know how to do it. and you're abandoning, like, it's also state. So, yeah, and it's.
I guess there's suggestion that we create this crisis plan based on, we're obviously not trained BCBAs to assess.
Yeah.
So really, how much are our crisis?
Yeah.
And we're not trained, but then this can't even be because don't respond to so then who's creating this plan?
What happens too, that plan may not be set someone without background in ADA, writing a plan, which should be written by ACA. There was one other solution, but at least I feel like we're starting to, you know, strike the problem. I'll show you a little bit from that. This is what we talked about, realistic expectations. I think the parents need to know that they need not going to have. I think a lot of times we talk about the model of my ear hurts, I go to the antibiotics, boom, your infection's gone, I go back home and that does not work like that at all. I'm going to the ED, just putting a back, it's not big at work, right? Sometimes they may be worse. So I think having that realistic expectation of even be where they need, it may not be what you're telling. If you can safely navigate the crisis at home, safe situation, don't go to the ED because it's not going to help anybody. And the other part too is this realistic expectation of even if your child gets admitted, it's still need to go back to the so you need to get training. There's no such thing as a magic wand that will make this behaviors go away. You need community support to meet the patient's needs. Sometimes the parents just rested. I've heard parents tell me like, I'm here, I can't. I just need something to take for a couple of days. And sometimes they're using the ED as rested because they try to get rested as they try to this nightmare of paperwork and signatures and approvals and authorizations. So guess what, right? They are, it's way more convenient than going through the nightmare of all the. So having that support in place of like offering, getting the rested, getting all these supports. And, access to evidence-based treatment and removal of barriers for treatment. Parents, my kids don't have autism, but every time I explain the process to the parents, I'm like, how do they? It's so getting the approval, first of all, getting them diagnosed with approval of your parent is hard. So removing the barriers to get that. After that, you pick your diagnosis through a lot of days, and then welcome to our wait list, right? So then you have another wait list for ADA, and if you're working with your provider, it's qualified to go to treat. It's just, it's difficult. So I'm saying is like, I think it's going to get better, but it's going to take time. And this is something that I think we can figure out to kind of manage crisis at home so we avoid the visit. So, and then train medical professionals on how to care for this population. That's another big one because if you have nurses and doctors, and right now what we're doing is we're training pediatricians and providers from behavioral health to when they see a 9-year-old, 8-year-old, or 10-year-old who's engaging in problem behavior, to send us a referral for severe crisis behavior training, or I'll show you the video in a minute, for crisis management, so we can catch them sooner. I don't want, I will help people, but what I want to do is I want to catch them sooner. I don't want to wait until the point where the parent is exhausted, tired, they can't function anymore. They want their job to check out for them. I want to catch them sooner. I want when the parent goes to the pediatrician and the express concern about aggressive behavior, those are the concerns. They're 8, they're 9. So I can train the parents on behavior management, and then hopefully we're going to be avoiding ER. And then, like I said, educational for hospital staff and crisis management training for families. We do consultation services for emergency departments, so sometimes we'll do care conferences, so we'll go and offer some resources and training for the team. It's very hard, really hard. So we've done that consultation with our emergency departments. During the conferences, we help the team collaborate, we work together. Even simple things of like, hey, we'll get you stickers, toys, we have what we call our frequent flyers. So they come in, they get discharged, they come back. We help the team understand what resources are needed. And we can provide some better suggestions. If they have a provider, we call them, collaborate with them. A lot of times, this family just needs specialized case management. So they just need someone who's helping with school, someone to kind of like put the scripts together. One of the patients that I worked with, he was a man, he was 14. He had a big covers. He could have gone and he did. He fell through the cracks. That said, they tried ABA like 15 years before, but they're another time and it didn't work for them. But this is an example of training on how to do this safely at home, so they didn't have to go back to the we've been able to successfully keep them out of the league since the first initiative. This is the trying to get all the nurses off the floor. For training, it's different. You can't just put a sign on the door that says we're closed, we're training. You need to have all the time. So it's very difficult. The logistics of training people. So what we do is we have training for our third that extra lunch. We have report training for those who try to make a menu of options so they can plan. So this is a video of the program that we created to train families on crisis management. Oh, hold on. And this is not working. Why? Sorry. It's not going to work. Okay, sorry. I'll try to play it at the end. Basically, it's a video that describes the program that we're doing. What we do is the patients that get referred to us from RDs or pediatricians for behavioral health that have red flags for potential severe problem behavior. First, we do an evaluation to get an idea of what behavior is happening and what condition, or what we do amount of that background, and we do an evaluation with parents, and then we train them. We have two curriculums that we train. The first one is QBS, behavior for family. There's our behaviors. So it's a curriculum that basically trains caregivers how to manage your crisis. So 80% of it is focused on prevention of behaviors. 20% of it is focused on, well, it is 80% prevention. These are some things that you can do physically, right? Like physical to manage the crisis so people don't get hurt. So that is a 6-hour training. We chunk it up into 3-hour blocks. So we have 2 certified trainers in our team. So parents come to that. We train them how to manage the users. 9 out of 10 parents say, "Oh, I wish."
So I know you guys said they are typically reported by the emergency department. Is there a way for, like, we have families that we wanted to report, like, how do we go about that?
Yeah. ABA, I think okay. Might be your all information. But yeah, so we first teach them like how to get out of the crisis. So that's the first curriculum we teach them. It's very structured. It's step by step. These are some things that you can do. Once we get out of crisis mode, we go into okay, now that we have the tools to manage to do what happens at home. Let's talk about functions of behavior, functions of management. We go into kind of like really basically down on ABA training for parents, so they it's a longer training. Sorry. It's a longer training, and the original program is like 12 weeks altogether. But it's for the parent, not for the kid, it's for the parent. If you're going to residential, eventually they need to go back home. So we need parents who are trained on how to implement this. So first we do PBS and different training for families, and then we go to Ruby. Ruby training for disruptive behaviors. And it's a really nice curriculum that has 11 sessions. Now, by the but then we can really train parents how to manage the behaviors at home. So, like I said, first crisis, how to get out of the crisis, and once we're done with that part, go to like, okay, how do you identify, triggers for these behaviors? What do we do to prevent them from happening? What are some simple environmental education critical for your child doesn't engage in this behavior? Behavior is communication. This is something that I say all over in every comment percent. Our kids don't being wrong behavior because they're kind of they get wrong behavior because this is how they communicate. This is how they learn to get their needs and wants met. We need to teach them ways to do that appropriately so they don't need to learn wrong behavior, right? This is what this training goes about. It's training. Sorry, my idea doesn't work. But if you go on our website, or you can go on to the crisis management training for families and before. Okay, this is what we were just talking about. Yeah, it's very important. I think it's what you were saying. Here, that is here in our state, in our country, that was here before COVID. It's still here. I think now. I still think this can improve. I think it's a problem that needs a multi-layered solution. We need, more residential placements, right? Facilities to be able to care for this patient. Give them the facility. We need our caregivers train them how to manage this on behavior. It's really difficult to staff this residential facility and staff them appropriately. It's very difficult. So even if we have them, we want to make sure that it's a proper treatment, right? So I think the more we can train our parents, I think that's where we're going to see less issues. And I worked with so many parents, the kids who are like 17, who were like severely aggressive. And I remember I worked with this much with the UP, and her kid would engage in fecal parents, because they would put all over the wall. And I worked with mom through virtual care on identifying what was triggering that behavior, why was he doing it. We realized he was asking for a bath, so every time he did that, mom was like, oh my gosh, this is disgusting, obviously. She would give him a bath, so she was bringing it to do something with the gloves, get access to a bath, right? So we did some small environmental modifications around this and gave him his bath, and he asks for it next week. Put it on the calendar so he knows when he's getting his bath. If he doesn't, don't give him a bath, because that's how he's requesting bath, right? And the mom was like, you want me to not bathe him after he does that? I'm like, yes, I want you to not bathe him after he does that, because this is how he's getting access to his bath. And then, once he realized mom was not giving him a bath after doing that, he was like, what's the point? I'm not going to do that. So I guess what I'm saying is like, this kid did residential, right? He needed mom needed some training on. It's very easy, and I see that as a mom too. Like when you see your own kid, it's so difficult to see, and you're immersed in the craziness of schedules and schools and all these things. It's very difficult to identify this small thing that really has. I mean, shoot, like thank you so much for not letting. Now my kid doesn't keep my walls anymore. Right? So this was a very simple environmental modification. This kid didn't need residential, but because mom received the caregiver training she did, we were able to help her, and the kid stopped doing that. had other behaviors on that side. You know, it was, but at least he stopped painting the walls, right? Which was improvement. I mean, it's having a better quality of life, little by little. That's what we want. There's no such thing as a magic solution. There's no such thing as a magic pill. That's just not possible. So I think our goal needs to be how are we going to make their lives a little bit better day by day. So if you're a BCBA or a provider, what are some things? I know it's hard because I know I'm a BCBA myself, and it's so hard to apply the ethics, apply the insurance requirements, and on top of that, attend to all the things. There's no treatment. It's just like you feel old and you don't lunch. So something is recognize your scope. And if you're not qualified to your problem here. And I know we make some families upset. But, you know, if our ethics come, we can't do it. I would not like to go to heart surgery with someone who does not have experience doing that. Same concept of ICU, right? It's our responsibility. I'd rather make a family upset for doing the right thing than the opposite. And if you're a parent and your provider tells you, sorry, I can't take your kid because they're too severe, I know it's frustrating, I hear you. But I think it would be worse if they take your kid and they don't know what to do. Right? So I'm just showing you the other side of the picture, right? Obtain ongoing treatment of severe chronic behavior. The experts of severe chronic behavior, we are the ones that wrote all this. They use the articles in Java. They're very focused, right? On the building and the small crazy. So you can reach out to them. You can look for training opportunities. Just keep getting training. Don't just go for the team that you need to keep getting training. If you're going to get a team who has severe chronic behavior, make sure that you're getting good supervision, good mentorship, that you're working under someone's wing that can provide you that treatment. Sorry, that's supervision. Go into Java, see what they're doing out there. Read articles, see. I feel like Java sometimes is so underutilized. Go in there and see what people are doing. In terms of training, if you have to train other providers, it's very important to meet them where they are. If I would go into a training with a nurse and a doctor and this is the thing, like, you guys are doing it all wrong. This is not how you treat people with autism. A minute. So it's very important to understand where they're coming from. Why are they doing things? And you know, I remember the first time I went here, I was like, they have to save people's lives while providing care for someone who's autistic. So this is the same thing that if I would have to care for people who wanted it, well, trying to do CPR on someone else, right? It's not easy. They're doing two jobs. It's not easy. So, and then collaborate with other professionals. See what, come to events, getting training, making sure that they're getting a lot of supervision. And then what caregivers do to prevent this? The more parents get trained on ABA and behavior management, the less they're going to have to rely on all the services. I don't think you want to be BCBA, but that's another story. But if this is not your quality of life, you don't have to be BCBA, but you need to know this behavior management principles to be able to help your kid. And that's, if you learn this lesson sooner, the likelihood of your child going into the ED is a lot lower because you're going to know what to do with your child if they go into a crisis. Identify how to select an ABA therapy provider with experience in behavior management. Ask them about their credentials. Do you have a BCBA, a PhD BCBA on staff? Do you have someone that you can, if they don't have a staff, do they consult with someone who's PhD? Have a crisis plan in place. If you don't have one, talk to your BCBA team, or talk to your BCBA or your ABA team, and ask them to create one for you. This is huge. Learn the difference between evidence-based and recreation. Not everything that you're doing is treating the core symptoms of autism. Be selective on the therapy. Sometimes less is more. It's better for a kid to get less therapy that is effective than to fill out their schedule with things that are waste of time, resources, and energy for both their kid and you. And then build a support system. Have that. That's not super easy when I say it. It's more difficult. Have a neighbor. Have some sort of aunt. take care of yourself before you're able to take care of yourself. So build that support system. So, because this is for life, right? So you need to be able to take them because your child's going to grow and you need to be there for them the whole time. Okay? Question?
I work in a place that has respite care and they have conversion. I can't say no to one of them because if I do, he strips right there. So how can I go about getting the training that you say so when we have these respite care kids and they lose it, how do we get that training?
So I would suggest, so this training is more for like caregivers. Well, and the state law, but I guess I'm saying, I would suggest you get training on AAoM. Which typically is for that's it, no, get more information. We also have flyers out there, so you can ask them for.
There were two of them.
Yeah. And then I also have Kate, and I know she likes her. Say hi, hello. She's one of our therapists, she works with it. And can I just say something? Today she took the day off, I thought she needed a mental health day, and I saw her get a conference. Talk about some dedication here. She took her day off to come here. That's some dedication, right? Right. Yeah, from the minute they come into the program, we start working on building independence because it's what's good for kids. Our program we have for its early intervention, so I think at that point we're working more on communication, motor training, some basic school. But when kids are older and we do crisis management, yes, we do a lot of we talk to the parents about building so that they're ready for the future. All right. But thank you for coming. If you have any questions, feel free to email us. And I know, like I said, I don't have a magic solution for this, but at least we're going to be able to deal with it better. Okay?
You guys care about, we are